Hello, everyone, and welcome to the Ultimate Health Summit. I'm Karen King, and with my co-host Selma from Radis, we're so happy today to be talking to Dr. Melissa Cady. She's the author of a book called Paindemic, and she's also known as the Challenge Doctor, who is driven to champion the cause of living the anti-pain lifestyle and minimizing the current paindemic that is so rampant today. Melissa Cady is a physician trained in an osteopathic medical school, followed by allopathic training in general surgery, internal medicine, and anesthesiology and pain medicine. Dr. Cady is currently board certified in, here's that word again, anesthesiology and fellowship trained with a board certification in pain medicine. Prior to medical school, she worked as a personal trainer and as an aide for physical therapists. Welcome to the Ultimate Health Summit, Dr. Cady.
No, thank you for having me. It's a privilege.
No way, it's just an honor of ours. So let's just let me take the first question here. Now, chronic pain is an issue that is near and dear to your heart, but not just as a physician, but as a patient as well. Your own pain experiences in combination with your, diverse medical background has equipped you with a unique set of skills and invaluable perspectives. So let's start off by you telling us what pain is and its role in our lives.
Absolutely. Well, most of us can feel pain. Actually, I don't think everyone knows that there is a very small segment of the population that can't even feel pain. And it's called a congenital insensitivity to pain. And I like to highlight this condition because it actually reminds us how important pain is in our life. And in those particular individuals, when they're children, you'd think it's hard enough to be a parent to raise a child in this world. But when they can't feel pain, one of the issues they deal with is the things that would normally keep them from doing or harming themselves. They keep doing it. So like chewing their tongue or nibbling on their fingers or hitting their head against the wall because it feels cool. Unfortunately, that can lead to devastating circumstances and, either internal bleeding of the head or losing their tongue or fingers. And so that's just a very brief explanation of the kind of lives that people can live in those very, very rare individuals. But it's a reminder that pain is really there to warn us or be an alarm or to give us some indication that something's not quite right. And it means that we actually should pay attention to it. And many times in this country, we're trying to just put it away and not deal with pain. And I think that's at a disadvantage for us. So if we think of pain, it really is an alarm. It's there to guide us. And as much as it's not enjoyable, pain really is, not just the sensory experience of feeling pain, but it's also an emotional experience. So I like to remind people that if you stub your toe when you just had a breakup in a relationship versus stubbing your toe when you won the lottery, it'd be a totally different experience. So it's not just this biological phenomenon. I mean just that, okay, I stubbed my toe and it hurts and there's some receptors saying, hey, there's something going on down here, pay attention. The brain has this capacity, if it's in a really heightened state of happiness, that pain won't be really as bad as, it would have been, say, if you were down in the dumps and feeling horrible about your circumstances.
Right. Wow.
And so pain, is really, it's very helpful in our lives. It's not what you call, like an emergency, right?
Correct. Most of the time, pain is not an emergency. Unfortunately, there are a few circumstances and a small percentage of people that there are red flags. If there's an emergency, say a major blood vessel, burst. I mean, that obviously that abdominal pain of your aorta, if that happened, that's definitely an emergency. And there's very few circumstances where in the back, which low back pain is such a huge issue, not just within this country, but throughout the world. It's a human condition that happens to many people, if not chronically, at least it's some acute phase in your life. But most of the time, back pain is not an emergency, and that's what the physicians are there for. They're there to guide you to make sure this is not a red flag. That's the primary thing you want to rule out. And it's very rare to have a tumor or cancer, but there's definitely things that you look at the big picture and the story of the patient, and that will help guide you as to something doesn't seem right. And so those things are, there are the emergencies, but most of the time people get worked up sometimes when it's really not going to be an emergency. It's horrible experience, but it's not usually an emergency.
Right. So when we have this horrible pain and everything else, it's always that we know sometimes we will run to emergency or something, or run to the doctors, and sometimes we want that medication, we want an injection, some of our present physicians are still using this kind of outdated medical model, aren't we, Melissa?
Absolutely. Well, the problem, so I'm a DO, and so there's two types of physicians, just to remind the audience that there's MDs and DOs. When it comes to physicians in particular, and probably about 85%, don't quote me on that, but there's definitely the majority of physicians are MDs, and then there's DOs. And so I'm a DO, and so we just learn a little bit of, it's a philosophy, but like for any physician, it's how you carry that philosophy throughout your career. But we learn a lot of assessment and manual skills and whatnot, but that's helpful, especially with the musculoskeletal system from a DO perspective. You're very comfortable touching, putting your hands on patients, assessing tissues, and so, and knowing when that's relevant is really critical too, so sometimes that can misguide us. But the issue is that most physicians are not trained well on, and you probably know this, is nutrition. That's like a no-brainer, but self-care skills, and that includes the nutrition and also movement. And so many of the things that are being prescribed for patients are very much symptom-oriented. And so that also gives the perception that to a quick fix society that it is something as simple as just taking a pill or getting an injection or potentially having surgery. And so when the people that are trained are not getting the full training on pain or all these other things that could contribute to pain, like poor movement or various other inflammatory conditions that they may not be aware of. But if they are not aware of these other alternatives, then as a physician, which is technically a teacher, if they're not educating patients on ways of maybe dealing with the root cause and trying to find other ways to deal or cope with that type of pain, then they keep projecting and perpetuating this symptom-oriented approach to pain care. And really that's not serving the patient because you're not allowing them to be active. It almost takes the power out of their hands and seem really dependent on the medical system. And you have a very passively oriented type of pain population that I call it the pain train, because they just have to keep coming in because you're not dealing with the actual issue unless they get lucky and it just resolves on its own. And I prefer patients to be more of using the medical system as like a bridge and just to help facilitate it and help educate you.
Good luck with that. Right? And yeah. Would you say, and I'm not going by the script here, do we have to always have something physically wrong with us to experience pain, or is there a lot of emotional undercurrents going on? Maybe a story that somebody's been carrying through and, yeah?
Well, there's absolutely every single part of us is important. So there's this pendulum that keeps swinging where it was all about this symptom or that's the actual source that seemed like where the pain was at, and we just treat it and hammer it with opioids or other types of pain medications, and we weren't listening to what's going on with the whole story of the patient and maybe the trauma that they had gone through, maybe the underlying anxiety and poor relationships and just not being fulfilled in many other ways in their life. But there's a huge shift to just dealing with how the brain is, of course, this is where your pain is felt. And so there is a huge switch to focus on that. But I always caution people that we should never let the pendulum swing the other way and ignore everything else, and that we should realize that every component, our biological, our psychological, our spiritual, all these different components of who we are very important. And the challenge, and I think the biggest challenge for all of us, is to figure out what part of this big picture is the biggest issue for that patient. And it doesn't mean that these other areas aren't important, because you still have to address them. Sometimes you have to go back and reassess and realize, oh, maybe that was important. And so that's where that journey of pain and trying to figure out what's the best solution for that individual is critical. But to make a point about your brain and everything being here, a lot of people, you can think of kids that actually have a lot of anxiety and they get abdominal pain. That it may have nothing to do with their abdomen being something wrong. It's just the nervous system is so integrated to every component and has almost its own nervous system within the actual GI system, and they all kind of interact. So absolutely that happens. But also another interesting phenomenon that not everyone thinks of is if you have a amputation and they still sense that limb is there, say they lost a foot.
That happened to my dad. He lost his leg, yeah.
Right. So but the other thing that goes beyond that is they might feel pain, and yet people on the outside can't understand how they perceive pain in a space that has nothing occupying it.
Right.
And so the power of the brain to still perpetuate this sensation, and maybe it feels this cramping of the last position it was in, the last signals and information that never went away and perpetuates. It's phenomenal. There's a great book by Norman Doidge, The Brain That Changes Itself. I think I'm saying that right. But there's so many great stories of people that the brain is dictating what you're perceiving in your body. So it's all playing together.
Yeah.
Absolutely.
I was in a really, really bad car accident decades ago. And I was rear-ended and front-ended at the same time on a highway by two drunk drivers. I was just sandwiched in between, right? And, I was fine, and they wrote me off. You're fine. Went to the doctor, blah, blah, blah. And about 7 years, all this pain started, right? And I was going to physio at least 3 times a week, at least. Couldn't walk from here to the end of the driveway, And then I've heard about a new chiropractor in town. He had just finished his training. And I went to see him. And he said, well, tell me what happened X amount of years ago. Well, I was in a really bad car accident. He said, that's what's going on. It's cellular memory, right? My body was still remembering the impact of this. And it was just acknowledging the fact that it was cellular memory, and the pain went away.
It's amazing, and I really do believe that there's some of us that are more sensitive to those however you want to define it, from this intuition, this memory, this ability for your subconscious to never forget what happened to you. I really believe that we're all wired differently, and that some of us are, this is my favorite example, is that some of us are like a tight wire, and some of us are like a loose string. And depending on our basic, background of our personality and how we're born, and all the incidents and experiences or traumas that have happened to us throughout our life can dictate how taut that string is.
Right.
And so when you look at that wire as you and something touching it from the outside, if you touch it and you're already wound up, have this underlying anxiety, you touch it, anything like even a little bit of pain will be an exaggerated experience of pain for those people. Yet I also find the opposite, where as far as treating that, they may be more sensitive to what might seem innocuous or not like a big deal. Like, how could that really help pain, or just the way you talk or perceive it? And I find that some of those sensitive people might be the kind that respond more to it. I mean, it's totally theoretical in my eyes, but I definitely see those types of people that they're like a loose string. You touch it and the whole system's like, oh, that doesn't bother me. And it's amazing how distinctly different some people can respond to the very same, thing that happens.
Yes.
So.
Yes. So what do you think the most common mistake is that pain patients make?
Well, we talked about the quick fix. That's definitely something. But I think there's a real deep-seated belief that technology that better and newer technology is going to make the biggest difference, and the next new thing is that almost oversimplifies pain, as far as I'm concerned. And so there's this, unfortunately, we have all this imaging, and people believe that what they see is connected to pain.
Mm-hmm.
And what they don't think about is that may have been your first MRI, and I'll just say low back for an example. They look at that image, or they're told these are the findings, which sound in another language always sound important. And it's very scary when you don't understand. It's just like not knowing another language or creed or anything unfamiliar it creates a little fear. But when they hear these strange names, then it induces a fear, which first of all is not good. But what people don't realize is that's probably your first MRI.
Mm-hmm.
And many of the changes that they describe on these imaging tests, most of these are chronic changes. They don't necessarily happen overnight. So for most people, they don't have a red flag, and we could talk about that, but things are really concerning, like shooting, like you suddenly can't move your leg, or you can't control yourself bathroom-wise. I mean, there's certain things that are definitely acute, but most of these imaging tests, they don't give you a big picture. You're laying on your back most of the time. It's one snapshot. It doesn't give you a 360 view of how you're moving. So it's just like me saying, I'm going to treat the monitor that has all your vital signs and not treat the patient. So if you have artifact and it's really not an arrhythmia, I mean, that's just an example, that does a disservice to the patient. So you really need to know the full picture and understand them and how they're moving, other aspects of their life and their story. So the biggest mistake, I think, is relying on these tests to tell you, and this is your problem and this is causing your pain. And that, in a way, disempowers you because it feels like you can't fix it and you can't do anything about it. And so, unfortunately, physicians project that type of connection because they don't have the skills to tell them other reasons why they have their problem. And it's not always easy to answer what the real problem is that causes their pain. So, and I'm saying out of admission of our own population, despite their caring physicians that really want to help, sometimes you misguide patients and actually are worsening their pain by putting fear in their head, making them think they can't change it, not giving them the skills to help themselves, and then give them a script of something that's easier to give and start than it is to start, stop and take away. So that's I think the biggest thing is people focus on those imaging findings and then want to go to some kind of passive treatment to fix that when that may not even be the problem.
Right.
So that active treatment, like why did we get involved with the use of opiates for, kind of like, we understand opiates for cancer, palliative care, and everything else there too. But I think since the 1990s, I think I've been reading some statistics or something like that for non-cancer chronic care opiates, their prescriptions have skyrocketed and now we have, like overdoses and, in risk factors and everything else. So tell us what's happening there. What are some of the reasons?
Sure. Well, it's extraordinarily convoluted. Many layers. They can get very political and whatnot, but there was this push from some physicians and some pharmaceutical companies to try to get across to patients and physicians that the addiction risk is extraordinarily low, and I think 1% is what they're saying. But we know that there's more risk than that, and aside from just whether it's addiction or not, of course, anytime you're exposed to a medication that you can build tolerance to, you have to go escalate your doses to get the same effect. The problem is you start having constipation, respiratory depression, and in our aging or increasing size population, there's increased risk of sleep apnea. So you combine sleep apnea on top of opioid use, then you have a serious problem that when you're sleeping, that suddenly you have this collapse of your soft tissues, especially if you're laying on your back. And so it doesn't allow you to breathe in and out. You don't have the same, when you're affected by opioids, which are essentially the painkillers everyone talks about, it actually depresses that and collapses your airway, so you can't get air in and out. And you may not come to quick enough to realize your body starts freaking out actually and tries to increase a tone in your neck so you can start now breathing again. But many times people do that just with sleep apnea without the opioids. And then if you add that in, it makes it worse and you don't recover or can't get yourself to wake up better. So that's the most common reason. But as far as the why we have this opioid epidemic, it's the same thing we said earlier, is that if you don't give the skills to the physician, first layer, the primary care physicians, they have a hard enough job keeping up with everything else, but you don't give them the tools or the skills, and the only skill they know in a very short visit with not enough time to hear the patient's story, which is critical, not enough time to educate, which is critical, especially for the brain, they dish out a prescription. And so those prescriptions, with all these issues that I just talked about, some of the risk factors or the things that can happen, such as people dying, it's real. Of course, even if you take it correctly, those things still could happen. And does it help some people? Sure. However, there are other options that are not being delivered because the people delivering on the front line, they don't appreciate those other options to help patients. And the sad thing is that a lot of these opioid painkillers and medications are getting in the hands of friends or other people, not necessarily prescribed directly. So you have a huge supply of unused, even after surgery, people don't use all their medications, they're still sitting in their cabinets. Kids or other friends try to get, they think because it's socially acceptable way to treat pain, that it's safe enough to just take it. And the problem is too, is that now we're treating anxiety with anti-anxiety pills, and you add that on top of opioids, that's where we have a huge dilemma, and alcohol. So you mix those together, all of them depress your breathing and make it more likely to obstruct, especially in sleep apnea patients, even if you're not. So you end up with this big mess, and now we have a society that believes that this is the way. Now, obviously, we're realizing it has its own issues, but now we have people coming in to create the guidelines to cuff the hands of physicians to say, you know what, you can't go over 90 milliequivalents of morphine. That's just a certain dose that they picked. But in reality, there are some patients that can take twice that and have no trouble breathing. And there's an art to, you don't just say handcuff the physicians and tell them don't prescribe these. You need to give them the skills to pass forward to the patients. And you don't just take away the opioids without giving the bridge to come to a place of less pain without the opioids. So the biggest mistake is, and this is just an opinion, I feel that when people try to come into the practice of medicine and they don't realize that it's not cookie cutter and it's not straightforward, and there's certain people that can handle medications and some people might be at high levels and you need to wean it slowly. You can't just rip it away from them. There are other problems that are going to arise from that. But I think my biggest focus is there wouldn't be such a big deal about the opioids if we really focused on the primary issue of giving better skills and not just dealing with the symptoms. Why don't we deal with the root cause and help dig down? And unfortunately, in the insurance-driven model, you're not going to have the time, if you live in that world of insurance, to deliver what patients need.
Right. But also there's a reluctance from physicians to, refer, like sometimes to a chiropractor like Karen's experience, or massage therapist.
Well, that never happens. That never happens. You've got to do that on your own. Right?
No, but some do that. But there's always a reluctance, right?
The best people that are good at referring to, and there are variations in skills in all professions. So that's another dilemma.
Right.
But the best referrals to other areas that are less appreciated by most physicians are when the physician becomes a patient themselves and the light goes on.
Yes.
And they realize, they're humble enough to realize that, you know what, maybe I wasn't taught everything I need to know.
Yeah.
And so if we don't get to a place where we collaborate, and if we don't get to a place where we let our egos come down and realize that we're in it for the patients, not in it for our pockets or ourselves or to maintain our ego, then we're not going to get to where we need to go.
Mm.
And there's a lot of pressure on physicians too from the pharmaceutical companies, isn't there? Like, visiting and appointments and everything else there too. I mean, they right now, some of them, the waiting lists are weeks and weeks, and sometimes they only have a bit of time to see a patient, and sometimes it's like one topic, one visit or something. You got three things, wrong. You got to
Make
schedule
another appointment. Yeah.
Yeah.
Right.
Yeah.
Well, I find that the most satisfied physicians are the ones that are pulling out of the insurance to third-party payers that are dictating the value of what the physician or other professionals have to offer for the patients, and the ones that are pulling out and doing direct care and allowing that middle, that piece of the pie not to be interrupted or taken by other people that are not really into the relationship of the patient and professional.
Okay. All right. Wow.
And I think, your medical system in the U.S. is different than ours. Ours is everything that government pays for. So unless, of course, it's chiropractor, massage, physio. And you know what? I don't even think we have osteopaths here in Canada.
Really?
They're not recognized here in Canada. And yeah, I know some people that were trained as osteopaths from England that tried and they were shut down. So
Right.
it's a little bit different here, but the common thing is that the patient or the doctors still don't have enough time to spend with the patient.
Right.
That I think that's universal,
Right.
Well, as you said, Dr. Cady, it's just listening to their story, right? There's got to be something a little bit more. And sometimes, they have to do everything within that maybe 20-minute segment. Sometimes that gets lost, right? What's the real reason what's going on?
If you get 20 minutes, do you ever get 20 minutes?
Sometimes.
I think it's 10 minutes.
Yeah, I honestly, if we're really going to serve the pain population, in most cases, that's never enough. And until we come to appreciate that, there are a few cases where you can do that, but that is something that we're losing connection in, I think, our general society. We got a lot of communication online, but really connecting with people, I think, is going to be a huge, there's just a huge void in satisfaction with relationships. And that's where I think that some of the non-physician professionals are really honing in on, is that they're actually able to connect human to human and feel like they're heard. And then they're able to receive the education, the patient can receive the education, and they actually feel empowered, and they have an opportunity to actually improve their life. And I think that's where a lot of dissatisfaction has been happening with physicians. And I think the physicians are very unhappy too. I mean, there's a reason there's 400 suicides a year of physicians in the United States. It's a real issue, and I find that the physicians are they're victims treating victims. If you're in the system, I hate, it sounds so bad, but I really, to a certain extent, I think it's really true. And I just wanted to mention from something you said with the osteopaths, I didn't make a clarification. So osteopaths are kind of considered more musculoskeletal specialists and not full-fledged physicians, depending on what part of the country you're trained in. We're just a very unique kind of a melding of the MD-DO training for DOs. And so in other countries, actually, I think Australia just a few years ago recognized DOs as full-fledged physicians, because they usually just see osteopath. A DO is not a physician. But we can do any field that any MD can in this country. But it's very confusing. So I just wanted to mention that
I appreciate
depends
that.
on,
I appreciate that. Okay, so how do we avoid this pandemic? Maybe you could explain the anti-pain lifestyle for folks.
Sure. Well, I consider it more of a philosophy. It's not like a trademark exact, but it's more of a lifestyle based on healthy challenges and choices that are used to facilitate self-care in conjunction with the medical system, but a rational use of the medical system. And so kind of what I alluded to earlier, it's all about using the medical system as a bridge to help facilitate a healthy lifestyle or wellness, and where the power is still kept in your hands and that you're engaged and active in participation. There's always going to be moments in our life where sometimes we feel much more dependent on the medical system, but the goal should never be to keep you there. The goal should be about learning the things that can help you improve your overall health and lifestyle, and that means less pain. I mean, if we really are searching towards more wellness, there's usually less pain, but we have pain intermittently that keeps reminding us, okay, you need to keep doing that. So that's really the gist of it, and it's more to just remind people that you have one body on this earth that you've been given, unless you believe in reincarnation. I mean, this is the one body you have, and for you to just be passive and let people do things to you and not try to understand why, it's a real big disservice to yourself and to your family or anyone else that cares about you, because there are real risks that any type of passive treatment could happen. And I've seen horrible stories of things that have happened to friends, family, colleagues, patients, and it breaks my heart because these things could have been completely avoided or never even had to go down that route. And we got to really watch ourselves. The system can let you go down a path that's really not in the best interest of society.
Well, you talk about breaking your heart. When you look at the paper, I think a couple of weeks ago about Tiger Woods, right? And they picked him up. They thought it was, he was driving under the influence, and then later on, it was discovered that he was taking some pain meds. Actually several prescriptions for his pain injury. So when you hear things like that, but what does that do to you?
I wish I could talk to Tiger.
Play around and golf with them.
Yeah, I would lose horribly. I don't even play golf. I really feel for him. I think it's hard enough to be in the eye of America and trying to live a life of perfection. You really can't. And the reality about pain is that all those things that he has to contend with just to be in the limelight that he's in, on top of dealing with pain, is extraordinarily difficult. And I wish that I could, along with several colleagues of mine we are totally in alignment. I know that we would love to be able to sit down with him and talk to him about the various ways of looking at things. And I'm not there to see precisely what he's been told. I obviously know that he's had some surgeries, but I do know of a lot of people that have, everyone's situation's different, but he's a high-end athlete. And so I just believe that there probably could have been a better way. And that's just my intuition from how things have been addressed to him and how he's projected a few things. I probably haven't heard everything, but I try to keep up because he's kind of a role model. And I cringe. I mean, you can just look at Steve Kerr. I mean, all these other coaches. It's scary because I don't like people having to learn the hard way. And the hardest part is trying to get people to kind of reframe their perspective when they already have this belief. And it's, even I put it in my book too, it's called cognitive dissonance. When you're trying to shift when you know that they're heading down the wrong path, they have this cognition, this perception, this belief, and you're trying to get them to not see it that way and see it differently, and trying to get people to open up to that before before they go through something, like horrendous, like, Tiger Woods is just really struggling, and Steve Kerr has been just suffering as well. So I just wish that you could get these kind of messages out to people before they jump into something that is really traumatic. All these interventions are technically trauma to the body, and there is a time and a place, but I don't think we do a good enough job, especially when our medical system promotes and encourages fee-for-service. So you get paid to do something. You don't get paid to just talk and educate.
Yes. So Melissa, just one other thing about, we've really got a fentanyl crisis here. And, and some people, that they talk about, to their doctors, well, maybe I should have that. Like what is the story there? Because we've got a real crisis here, I think in Vancouver or something like that. There's been 1,000
deaths this year.
Yeah. So, but people have said, well, maybe I should take, because for pain and relief and everything else there too. I think it's just that the name is mentioned so often in the media and everything else. People that, well, they take that for maybe I should or something, have that good feeling. Or what do you say to somebody?
I don't think that's a chronic pain way to address things. I mean, that is a very highly addictive, very strong, potent medication that's an opioid that I use in my part-time anesthesia practice. And it is something that, I mean, there are even people that are anesthesia providers that get hooked on that medication. And the sad thing is, you know, there's a lot of the naloxone. They talk about the reversal drug to help reverse things.
Naloxone, is it? Naloxone?
Naloxone, the generic. There's other brand names, but essentially how fast fentanyl works, it is incredibly quick. And even if you had naloxone, if you don't get that in your system almost concurrently with a massive dose of fentanyl, that however it's taken, and there's a lot of fentanyl I know is being produced underground in the black market.
Yes.
It's not necessarily, you know, legitimate. And that's the scary part, is if they lace that into other medications. So what I find is fentanyl is not okay outside of acute pain as far as I'm concerned. There are very, very small sliver of the population that has a very unique situation that maybe that is deemed okay, but a lot of times that's in the form of a patch. So it's a little bit throughout the day. However, you build tolerance to that too. And so it's just really scary when you have something that's that potent that can work so quickly in the system, and even the very thing that people are spending millions of dollars to put out there for emergency use to help reverse these things. The ability to get to it if you don't have someone nearby, I mean, it might as well not be there. And so it depends how it's being administered, and I'm definitely not the expert on looking at all the various non-medical ways of administering them, but it's a huge issue, and I've definitely seen some reports and articles about what's going on, but I'm not quite sure about a lot of the Canadian issues as much, but it's not the drug that you want to have on a daily basis. If you really want to cope with your pain, you need to find other ways, not just deal with something that deals with the symptom and causes other side effects.
Right.
Is there anything, for somebody who's listening to this interview, and let's say they've got some acute pain or some pain that just won't go away going on, without reverting to going to a physician first, and they know they've, maybe overexerted themselves doing something, what would you recommend to them?
Well, of course, there could be other symptoms. If there's like you're throwing up and there's other, concerning symptoms, aside from just, of course, pain can make some nervous systems get nauseated. That's kind of a normal thing for some people. But if you're having I have weight loss that's been associated with it, make sure you look at the big picture. If there are other things going on, then you should just be evaluated right away. But if it's just you can at least you perceive that you have a cause and effect relationship, maybe some increased activity, and you starting to get low back pain or some neck pain. If there's no other concerning symptoms, many times, if you give it a couple days, see if it starts calming down. Now, if you have had a history of cancer, that's just like another thing I said, to think about other things, then, that would be a reasonable thing to go and follow up with your physician that knows you already. But you can go to a primary care physician if you just want to rule out some red flags.
Okay.
That's reasonable. If someone you hadn't seen a doctor in a while and they just want to, I just want to make sure there's nothing overtly obvious. I'm not expecting them to necessarily fix my musculoskeletal pain if that's what it is, but I just want to put my head at ease and just make sure that there's no major red flag that as a non-medical person I'm just not in tune with. However, in some, and I'm not sure in Canada, but in some states you can go see, if you really think it's related to something you did, and he's like, most people say my back went out, which your back's not that vulnerable. It's a very, very strong structure. And so some places you can actually call up a physical therapist. And I personally, in my suggestion would to look for McKinsey Institute.org. You can look up some of the advanced physical therapists that are more in tune with it's an assessment method. People think it's just like a technique, but it's more of an assessment method that helps people just see if what your body's favoring or not favoring, and maybe help it get into a place where it's back to its neutral, non-painful state or less painful state. And you can find a McKinsey therapist and call them and find out if they can see you for an initial evaluation without a primary care physician's referral.
Okay.
So that's
Whereas I
an
just call up my chiropractor, say, can I come in? Yeah.
Right. But the other thing is that, you know, it depends. Some chiropractors are really good about educating. I say this about every professional, that anyone who's a body assistant, I call them body assistants, there's some people that are more passively oriented, and they're just going to do things to you. I have a preference for people that kind of marry those things where they have that at their disposal, but they try to look at the big picture and they try to educate you and teach you skills so that you don't have to see them as often.
Exactly.
So it takes some time to find the right fit for you, but I think it's critical that you can go to a chiropractor, especially if you have an established relationship already. But when it comes to movement therapies or assessing how you move in space and you think it's musculoskeletal, which is what most of the pain that's out there is, if it's not, you know, traumatic, you know, obviously there's chemotherapy-induced pains and, you know, that are survivors. And so there's other types of pain. But the most common ones, I would go to someone who is more trained in body mechanics.
Yeah.
And so, like you said, a chiropractor is, but some people can get a little bit too, even osteopathic physicians that actually carry that skill still. Sometimes people get a little bit more, I don't know, want to do things and it feels good to make people feel better. But I think there's something to say about us trying to be a little bit hands-off if we can let the patient help themselves so they feel empowered when they leave.
So Dr. Cady, also wanted to ask you, I went shopping at the drugstore a couple of days ago, and these two little ladies, you know, they had, like, one had Tylenol and there's 180 tablets, and the other one had, I think, like Advil, and, you know, they were talking, oh, I got to get the big one here because when I have the pain, I'm not sure I have enough of it. Like, you know, that is causing, these look like they were probably in their 80s or something like that, these ladies. But, you know, we got to get the big 180 plus another 20 is 200 pills on sale. And, you know, like, what is with that also? Because that is, you know, playing havoc with your body.
Right. Well, just to make a little aside is that when you don't give physicians skills outside of just opioid prescriptions, then they just fall back on the ibuprofen, the Tylenol. That can cause other problems.
Exactly.
So we need more skills for our physicians. So I say hashtag, you know, more skills, fewer pills. That's my hashtag. But that's what we really need. But the thing is that when you deal with Tylenol, if you have too much of that, you can have acute liver failure. Yeah. And when it comes to ibuprofen, you obviously, if you've been doing a lot of your reading, you know some of the big issues. But with people that are, as we get older, our kidneys, you know, parts of our kidney, they're not quite as resilient as when we're like 20 years old. So ibuprofen can cause kidney failure, and it can cause gastric ulcers. And I've seen people die or almost die from gastric ulcer bleeding in the ICU when I was in my training. You know, when it comes to acute kidney failure, even young guys that just think that they can pop that like candy because it's over the counter, it's amazing how it will just totally turn someone's life around. And so, you know, if someone's buying a big bottle, if it's just for cost savings, that's one thing. If it's because you have 4 or 5 members in your family, that's one thing. But to have that consistently every day around the clock, there's risk with that, and you have to be careful. And that's why it's a bridge. It shouldn't be a dependency. Again, it's all about bridging you and be smart with your bridges and not becoming on the train.
Yeah, thank you for sharing that.
Sure.
Okay, so, you know, the series is, you know, Ultimate Health to Live Life Well. You know, give us maybe review some strategies and, you know, how we can be maybe a savvier pain patient, but also, you know, how should we be living life well?
Sure. Well, sometimes, including myself, you have to slow down.
Good one.
And pay attention. Yeah. You know, the way I'm trained in my medical field, it's go, 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 and it's about what you know. And in reality, we don't know everything. None of us know everything. None of us are born with a manual. And so we have to keep that in the back of our mind, that you're going to another human being that's trained a certain way. and may expand their knowledge over time to help you. But if you're going to be a savvy patient, you have to try to understand your body. And as much as we may have gone through medical school, it's not that you have to necessarily go through medical school, but you need to pay attention because no one experiences pain like you are. If you're having pain, what you're experiencing is important. How it's affecting your life is important. Knowing what's important to you in your life is important, because if you can't function and spend time with your grandchild or whatever it is that really just makes you happy, then that pain is going to be much, much higher. Mm-hmm. So I think that it also is incredibly important that when people start giving you some advice and or it's definitely symptom oriented, one of the biggest questions you have to always ask is why. It seems so simple, but it's all about how you're perceiving internally what's going on. Because if your beliefs is that your back's falling apart, mm-hmm. and that pretty much you're done and you're only like 48 or 50 years old and you still have hopefully 30 plus years left of your life to go, that's a very horrible existence to really think of, so how you're processing, and that's why the engagement with your pain professional is important, is how you're perceiving, because they need to help, course correct you mm-hmm. if you're going down the wrong path and how your beliefs are. And so being able to have a conversation, ask questions, not to feel intimidated by a physician. And I know that sometimes you feel like you're put in a corner because they say, I only have 5 minutes with you. Mm-hmm. If you really have an issue that really needs to be dealt with, I know it's hard sometimes to go get a second opinion. If someone's not being conservative enough with you and it's definitively not a huge emergency, which is hard for some non-medical people to figure out which one is, sometimes getting a second opinion is helpful and maybe give you a little more clarity or maybe help you feel less worried about it. But the things I worry about is when patients are quick to accept a lot of these symptom-oriented treatments, mm-hmm. and I see them day in and day out, and they don't even know why they're getting them. And mm-hmm. they came and explain, and I know we're all of different intelligence levels, but if the person that's trying to help you is truly trying to help you, then they want you to understand. And so if you can't understand what they're saying because they're using this mumbo-jumbo medical jargon, then you need to stop them and just say, I know you're saying all these medical terms, you're very smart, but I want to make sure I'm doing the right thing for my body and for myself, and I really need your help with understanding this. And so I don't find enough people doing that. And it really bothers me at times when I hear patients say, well, you know best. I'm like, no, you need to be a part of this, because we're doing something to you. Mm-hmm. And so I just am all about empowering a patient. And if you want to be a smart pain patient, you need to be savvier. You need to understand your body better. You need to be, if the system you're working in, and I had to tell someone this, and I know it's probably going to take more money out of their pocket, but I said, if the system you're working in is delivering the type of professionals that are not able to spend time with you or communicate with you or give you or treat you humanely, mm-hmm. maybe you should just find a way to have money to go pay for somebody, direct pay, so you can get what you deserve, mm-hmm. and start paying for the value. Because if you're not getting value, mm-hmm. and education and just compassion, then the system's not working for you, mm-hmm. and you might need to go elsewhere. And so, I mean, I get to the point where if they can't find a way within the system they're working, then sometimes they need to go outside of it.
I think, though, that kind of goes back to the belief that the doctor's always right. And, let's not question, they're the professional. I think there's, especially a lot of older people, they have that belief that, they know, so I'm not going to question. And that's why I always go along with my mom to the doctor so that I can be the questioner.
Right. And you just pointed out a good point, is that if you can't be that strong advocate for yourself, you need to find somebody that can.
Yes.
And another caveat is that if you suddenly slash your arm and you're bleeding from it and you don't have time to understand, there are times when acute emergencies that are clear-cut are that's when you put it in their hands and let them do the skill that they have. I mean, obviously you still consent in a lot of cases, but when it comes to something as non-emergent as complex pain, that's got to have more engagement. So, and better understanding and better participation.
Yeah.
But there are times when passivity in the system, when you just had a car accident and,
Well, yeah, obviously.
you know, so, but sometimes people take it to an extreme. I think there's a time and a place for that kind of expectation.
I like that. Almost like the rules of engagement, right? I like that. There's a
So,
movie, I think. That was great.
Melissa, if people want to go further with your work, you've given a special offer called the Reframe Pain online course. Can you just take a few moments to talk a little bit more about your unique program that you've put together?
Sure. Well, it's more about how your view and approach can change pain. So it sounds similar to the elements I discussed. I kind of create a framework of 6 main issues that go anywhere from awareness and acceptance down to functioning. And there's 6 different video modules.
Okay.
And it's a total of about an hour and a half of content to just kind of reset your mindset on how you should go into it. Because many times if you start in the wrong way, you might find out later down the road that I probably should have thought about this in a little different way. So, you know, I also will have a PDF to kind of summarize a few things at the end of that course to allow people to kind of refresh whenever they go to deal with a pain issue. But that's essentially, I just wanted to give my perspective and how I think through my own issues with pain and how I think is a savvier way of approaching it.
Thank you. Thanks.
Oh, that's an excellent. I mean, you want that information from an expert, and you are the expert. So
Exactly.
Ifs, wiser, wherefores about that. But we thank you so much for being with us. Oh, you've opened our eyes in a lot of different directions. So thank you.
I appreciate you all. I appreciate you all. Thank you so much for having me on.
Thank you. And big hugs to everyone that joined us today. Until next time, live life well.
Bye, everybody.
Bye-bye.